Right. So we will be having a look at reading part B. Morning we discussed part A of your reading, and we discussed the approach. Then we discussed we practiced the latest material. So now we will be having a look at part B of your reading. So let's have a look at how do we approach part B. Let's start with that. Okay. All right. Okay. I hope. Okay. Give it a second. The screen is loading. Okay, so when it comes to part B of your reading, you will be answering 6 different questions, and you will be going through 6 different extracts. And these questions are multiple choice questions. So you can start with the question. You can start by reading the question, interpreting the question, then looking at the text. Finally, looking at the option. This is the best approach. Question, text, options. Question, text, options. Okay, or you can start with the text, then look at the question, finally look at the option. You can start with the text, then look at the question, then look at the option. So question, text, options, or text, question, options. So these 2 approaches are completely fine. Either one of them you can do, and the best approach being the first one that I've written here. However, never read your options before the text. So there is another third approach, that is people read the question, then they look at the options. As a final step, they look at the text, then they choose the option. So they read question, option, text, then they go back to options. So that is something, this approach is something that I would not recommend. Okay, either go with this or this. Okay, read your question, read your text, then look at the options, or read your text, read your question, finally look at the option. So either way, you can start with the question, then text, or you can start with the text, then question, final step being option. So either one of them are fine. And today, when we look at the material, we will be applying this method. We'll read the question, we'll read the text, then we will look at the options. Okay, all right. So let's directly move on to today's extract. Here we go. Okay, all right. Right. So Surya, can you unmute yourself and read the first question for me, please?
Yes, ma'am. The purpose of this guideline on enteral feeding is outline.
Is to out. So I want all of you to read. Okay, I want all of you to read the question. Tell me, what do we need to find out? So take a second, pause and read and understand the meaning. The purpose of this guideline. So we know we are going to read a guideline on enteral feeding. So, and the guideline is on enteral feeding. Is to outline. So what do we need to figure out here? The purpose of this guideline on enteral feeding is to outline. So we need to figure out what? Asma, Steffi, Anup, what do we need to figure out? Surya, what do we need to figure out? What do we need to figure out? All of you, pause and read. So outline, what do you mean by outline?
The overall, ma'am?
Not exactly, no. Outline. When you outline, to outline, that means it's an action. So to outline means to explain. So all of you go through it. The purpose of this guideline on enteral feeding is to explain what. So we need to find out purpose of the guideline. So there is a purpose. We need to find out the purpose, but the purpose is to explain what. Okay. So purpose of the guideline is to explain what. Okay. So the purpose of the guideline is to explain what. The purpose of the guideline is to explain what. All of you look at the question, look at the interpretation. All of you. Look at the question, look at the interpretation. The purpose of the guidelines. We need to find out the purpose. The purpose is explaining what. Okay, all right. Now all of you take 55 seconds. Read the extract. Very small extract. Quickly go through the extract. All of you. Do not forget the heading. Okay, all right. Surya, can you read the heading until here for me, please?
Okay, ma'am. Enteral feeding is the delivery of nutrients via tube directly into the digestive tract. It is only necessary and or desirable when nutritional needs cannot be met orally. For example, if patient has an illness or injury such as a neck or a head trauma which prevent them from eating or swallowing food.
So the extract is on, the guidelines are on enteral feeding, and they say that enteral feeding is all about giving nutrients through a tube directly into the digestive tract. They use a tube to feed the patient, and the tube is directly into the digestive tract. And this type of feeding is necessary or is desirable when we cannot feed the patient orally. So, for example, if the patient has an illness or injury such as a neck trauma or head trauma, which affects their swallowing or eating, action of swallowing or eating, then we feed them using enteral feeding. Okay. Next sentence, Surya.
Other indications include severe or sudden weight loss, poor absorptive capacity, and or high nutritional losses.
So whatever they have told, people who has an injury to their head or neck or that affects the eating or swallowing ability, other than these, enteral feeding can be given to patients who have other problems such as severe or sudden weight loss, poor absorptive capacity, or who has, high nutritional losses. Okay. All right. So Surya, can you read the whole paragraph, the whole thing? Yeah.
Yeah, ma'am. Patient with certain mental disorders, example, anorexia nervosa, severe depression, may lead to feed enterally, if they lack the capacity to make informed decision related to food or fluid intake. However, feeding against the patient's will should be an intervention of the last resort in the care and management of those with severe mental illnesses.
So they are like other patients who have a certain mental disorders such as anorexia nervosa, severe depression. Because of this, they cannot, they don't eat their own, so they need to be fed through a tube. Or if they do not have enough, the capacity to make a decision about their food and fluid intake, informed decision that comes with knowledge and information. If they don't have that ability, then as well we feed them through an enteral feeding. Oh, however, so they have explained who all will need enteral feeding. Then they're like, however, feeding against the patient's will should be an intervention of the last resort in the care and management of those with severe mental illness. Look at that sentence. All of you read the last sentence. If the patient, so they are like patients who have problems swallowing, eating, those who have weight loss, poor absorptive capacity, mental disorders such as anorexia nervosa, severe depression, all these patients might need to be fed enterally. Okay, that is one thing. And if they may need to be fed enterally if they lack the capacity, if they do not have the ability to make decisions about their food or fluid intake. Okay, but if we cannot feed patients against their will, against the permission. We can only do that as a last resort when we don't have any other choice, as a last solution. Only such a step, or like such a step can only we do enteral feeding without their permission. And this is for patients with severe mental illnesses. So feeding against the patient's will should be an last resort. It should be the last choice or last thing that you think about. When there is no other way, when you cannot do anything else, only then you can go against the patient's will and give them enteral feeding. Otherwise, enteral feeding should happen with the patient's permission. Okay, so all of you quickly go through it, go through the extract. All of you. All of you. Okay, All right, so we know the guidelines, we know the question. Now let's have a look at the option. As you can see, this question does not end in a question mark. So this is an incomplete question. For such questions, read such questions with the options. So when you read the options, read the question with each option. So Surya, can you go ahead and read the options one by one with the question?
Yes, ma'am. The purpose of this guideline on enteral feeding is to outline the type of situation in which it might need to be used.
The purpose
Second
of
one,
the, okay, one second. The purpose of this guideline on enteral feeding, it is to outline, it is to explain the type of situations, the scenarios in which it might. What is it here? What is it here?
enteral feeding.
Enteral feeding might need to be used. So the purpose of the extract is to explain the scenarios in which we can give enteral feeding, or we can have enteral feeding for a what are the situations where you can have or you may need to use enteral feeding. Okay, all right. Next option with the question. Yes.
The purpose of this guideline on enteral feeding is to outline problems that can be encountered when implementing it.
The purpose of the guideline on enteral feeding is to outline, is to explain problems that can be encountered when implementing it. Have they talked about problems that we have? One second, okay? One second, people are trying to join and they're struggling. Let me just help them out, okay? Okay, one second, give me a second. Okay. The first option says that the purpose of the guideline is to explain the type of situation where we need to use enteral feeding. Second option say that, as Surya has read, the purpose of the guideline on enteral feeding is to explain problems that we may have when implementing it. Have they talked about problems while implementing enteral feeding?
Nothing is there, ma'am.
Okay. Others, Steffi, what do you guys think? Anu, what do you think? Asma, have they mentioned about problems? No. So we are rejecting it. Next one. Next option, Surya.
The purpose of the guideline on enteral feeding is to outline the most appropriate way to assess a patient's suitability for it.
So have they talked about the purpose? The purpose of the guideline is it to outline, is it to explain the most appropriate way, the best way to evaluate a patient suitably for it. Evaluate the patients, whether the patient is suitable for an enteral feeding. So is the purpose of the guideline is to explain about the most appropriate way we can assess the patient suitably for the feeding. What do you guys think?
No,
ma'am. So of course, what is the answer?
Option A.
Option A. See, they have talked about, yes, correct. They have talked about many situations, right? When patient has head trauma, neck trauma, eating problem, swallowing problem, nutritional loss, anorexia nervosa, severe depression. So they have listed a lot of scenarios. They have explained a lot of scenarios where we can use enteral feeding. Okay, so all of you take a second, go through it. Take a second, go through it. Read and understand it. Go through it. All of you, go through the extract, go through the question, go through the scenarios. All of you. Very good question. You need to be careful. You need to understand why B is not correct, why C is not correct. Okay, now let's move on to the second question. Steffi, would you mind unmuting yourself and reading the second question for me? Yes, Steffi. Yeah.
The guideline of taking dogs to care settings state that in order to minimize the risk of infection.
Infection. That's fine. Let's look at the question. So remember, your reading is common for all professions. So you get questions on veterinary scenarios, okay? Dogs or cats, you get questions in from a veterinary scenario. So do not forget that. So again, let's focus on the question. The guidelines. So we are going to read the guidelines on bringing dogs to care settings. To care setting units, of course, healthcare settings, mention that in order to minimize the risk of infection. So this is a guideline that talks about bringing dogs to care setting, healthcare environment. And these guidelines state that in order to minimize risk of infection, can you guys tell me here, how do you interpret this question? Do not look at the option. Without looking at the option, this is an incomplete question. Tell me, what do we need to find out here? Focus here. Focus on this phrase, this clause. In order to minimize the risk of infection. So I'll tell you one thing. Whenever your incomplete question, a question that does not end in a question mark, such a question ends with in order to plus scenario. They have given in order to and a scenario. What is the scenario here? In order to minimize the risk of infection. When you get such a question as at the end of an incomplete question, such a clause, in order to, a clause starts with in order to and a scenario, in order to minimize the risk of infection, in order to start the treatment, in order to commence commence the procedure, something like that. When they give at the end of an incomplete question, when they give a scenario with in order to, you can interpret such question with the question phrase. What needs to happen? What needs to happen? All of you, go through it. So what do we need to find out here? Use this question phrase and interpret it. So according to the guidelines, in order to minimize the risk of infection, what needs to happen? All of you. So as per the guidelines, I'm interpreting it. I need your full attention. We have never dealt with such a question. We have dealt with questions that ends in order to. We have never dealt with a question that ends with in order to with a scenario. Okay. So as per the guidelines guidelines about taking dogs to care settings, dogs to care settings, in order to, as per the guidelines about taking dogs to care settings, comma, in order to minimize infection, in order to minimize or reduce infection, what needs to happen? Got it? All of you. What needs to happen? Or what should happen according to, in order to minimize infection. So all of you look at the interpretation. Understanding your question, interpreting it correctly is extremely important for OET multiple choice questions in OET. So all of you go through it. My question ended with in order to with a scenario, the scenario being minimize the risk of infection. So how did I interpret it? I interpreted using what needs to happen. So according to the guidelines, in order to minimize infection, what needs to happen? All of you. Surya, Anu, Shailaja, Asma, Steffi, others go through it. Okay, remember this, okay, when you have in order to with a scenario, just what needs to happen. Okay, all right. Now, I want all of you to read the extract. Take 55 seconds, read your extract.
If the owner and handler, I can't see.
You cannot see what happened?
See.
What happened? Okay, one second, Steffi. Let me check. One second.
Size is
yeah, 1 second. I'll sort it out. Give me a second. Okay, you can zoom out, Steffi. On your screen, if you're using a touch phone, you can actually zoom out. Okay, do you want to zoom in now? Is it visible?
The letter is very small.
Very small. Let me just zoom in. What about now? Tell me when you want me to stop.
Yes.
Okay, all right. So if you guys are using a touch phone, make sure to zoom in and zoom out so it's visible for you according to your visibility.
Yes.
Go through.
If the owner or handler.
Not now, Steffi, not now. Let everyone read it, then we will read it. Okay, take your time. Read
Sorry.
It's okay, it's completely fine. Okay, let's start. So, Steffi, please read the heading. Do not forget to read the heading. Always read the heading because sometimes there can be tricky situations where your answer can come from the heading. So, always read the heading. Okay, Steffi, can you start with your heading and read till here? Yes.
Guidelines for infection prevention control, dogs visiting health and care settings. If the owner or handler or dog are unwell with the diarrhea and vomiting or have been within the last 48 hours, they should not visit. This also applies to respiratory symptoms such as cough and cold.
That's it. So they are like, this is an guideline on infection control when it comes to dogs visiting healthcare settings, dogs visiting hospitals or wards or places like that. They are like, if the owner or handler, if the person who owns the dog or who handles the dog or the dog themselves are unwell, they have diarrhea, vomiting, or any such problems in a span of 48 hours, they should not visit any healthcare settings. And this also applies, they should also not visit if they have any symptoms such as cough or cold. If the dog or the dog's owner or handler have any of these symptoms, they should not visit a healthcare setting. Okay, all right. Steffi, can you read the next 3 sentences? Yes.
Patients may only receive visit if any exposed surgical cuts or incision have been covered. Both the dog and its owner must be up to date with all routines vaccinations. If the owner or dog develops a skin condition, prior advice should be sought from the local infection prevention and control team as to whether the visit should take place.
Okay, then they are like, if the patient that the dog or the owner are visiting, if they have any surgical cut or incisions, then they need to cover it up. Only then they can have visitors who are dogs or the owner of a dog. Their surgical cuts or incision needs to be covered. Now, and both the dog and the owner must be up to date with all their vaccinations. If the owner or the dog has any kind of skin condition, they need to get advice from a local infection prevention and control team before get advice before the visit takes place. Okay, so dog owner or dog handler or the dog itself cannot visit a hospital setting if they have diarrhea, vomiting, cough, or cold in the 48 hours prior to the visit. And patients can only get such visitors, a dog or the dog's handler or an owner, only if they've covered their surgical site or incision. Now, if the dog or the owner must be up to date with their vaccinations, and if they have any skin condition, they need to get advice from the infection prevention team whether they can carry on with the visit. Okay, all right. Now the next entire paragraph, Steffi.
Although stroking and petting and permitted, the dog should not be, lick anyone or sit fully on the bed, particularly not near a person's face. If the dog putting their feet on a bed, then the incontinence pad or similar should be put under their paws and discarded after each individual visit to avoid the contamination.
So when the dog visits the dog, you can put your hands on the dog, you can pet it, but the dog should not be allowed to lick anyone, or you should not allow the dog to sit on the bed, especially near a person's face. And if the dog put their feet on the dog's feet on the bed, then you need to use an incontinence pad or something similar under the paw, under the feet of the dog. The dog's feet are called that area is called paw. Under the paw, they need to keep an incontinence pad or something to prevent contact. And after the visit, that pad should be discarded after each individual visit to avoid contamination. So if the owner or the dog have any of these problems, they shouldn't visit. If they have a skin condition, they need to get advice. Patients can only receive the dogs or in their room or this one if their wounds or cuts are covered. They can stroke or touch the dog, but the dog should not be allowed to sit completely on the bed or lick anyone or come near the person's face. If the dog puts their feet on the dog put its feet on the bed, then the paw, beneath the feet, that area should be covered. Dog's paw should be covered with some kind of incontinence pad, which needs to be discarded after each visit. Okay, this is a different extract. We have never got such an extract. Go through it, all of you. So it's basically allowing a dog or its handler to visit a hospital setting. All of you go through it. Okay, all right. So Steffi, this is an incomplete question. So can you read each option with the question for me, please?
The guideline taking dogs to care settings state that in order to minimize the risk of infection, option A, animal should be carefully examined beforehand.
Have they told that we need to examine the animals beforehand anywhere? Anup, have they told that? Asma, have they told that? Steffi, Surya, what do you think?
Nothing,
Examining the
nothing.
animal beforehand?
No, nothing is mentioned.
No. They told if the owner or the dog has a skin condition, they need to ask advice beforehand, not carefully examine. Okay, so A is not the answer. Next one, Steffi, read the question.
The guideline on taking dogs to care settings state that in order to minimize the risk of infection, patients should wear the dressing on any open wounds.
Have they told that the patients should wear any kind of some kind of dressing on their open wounds in order to minimize infection? What do you guys think?
Yeah.
Come on, tell me, Steffi. Shailaja, tell me. Surya, tell me.
No. Only the owner or handler should.
What about the
Surgical
sentence?
Skin
wound,
condition,
something.
yeah.
This sentence which
Yes,
I've highlighted.
surgical.
Patients may only receive visit if any exposed surgical cuts or incisions have been covered. Whose surgical cuts? Patients, not dogs. So this is correct, right? How do you
Yeah.
cover a wound? How
Yes.
do you with the dressing, right? So B seems to be correct, right?
Yes,
Look at
ma'am.
the sentence. Look at the third
B.
sentence. All of you.
Patient may only.
Receive visit if any exposed patient can have a dog as a visitor or the owner of the dog as a visitor if they cover their surgical cut or incisions. How do you cover a surgical cut or incision? Using a dressing, of course.
Yes.
Okay, so Steffi, read option C as well. Then let's choose B. Yes.
The guideline on taking dogs to care settings state that in order to minimize the risk of infection, no physical contact with the patient should be allowed.
No physical contact. Have they said that you cannot have any physical contact when the dog comes to a setting?
No, ma'am. Nothing.
Stroking and petting are permitted, right? So no physical contact. Is that correct?
No.
No.
No,
Come on,
no.
tell me. Come on.
Option B.
Option B.
Option B.
Option B is the answer. So all of you go through it. Go through it. Okay. You need to know stroking and petting means when you do this on the dog's head, that's called stroking or petting. So petting the dog, that means physical contact is allowed. Examination, no told. Cover the wound means dress the wound, right? So that's why. This is the sentence that gives you the answer, this one. Okay, there, this is the sentence. Okay, all right. Now let's look at the third question for today. I want all of you to get ready. Here we go. All right. Shailaja, would you like to read the third question?
What is this memo saying about carbon monoxide monitoring for pregnant women?
All of you read the question. What is this memo? So we know we are reading a memo. What is the memo saying about carbon monoxide monitoring for pregnant women? So what do we need to figure out here? What do we need to find out from the extract? After reading, what is, what? Tell me, Surya, go ahead.
The carbon monoxide monitoring for a pregnant woman.
Mm-hmm. So what is told about that, right? Correct. What is said about, how is not there? What exactly? Yeah. What is said about CO2, okay, carbon monoxide, okay, CO poisoning, carbon monoxide poisoning in for pregnant women. So among what exactly is said about carbon monoxide poisoning in pregnant women, okay, pregnant women. Okay, all of you go through it. Go through the question, not the extract. What is said about, so they said, what is the memo saying? So we need to find out what is said about carbon monoxide, not poisoning, sorry, I wrote it wrong. It's monitoring, okay? That was my bad. It should be monitoring, okay? Carbon monoxide monitoring in pregnant women. When you monitor for carbon monoxide, what about that, what is said? All of you take 55 seconds, read the memo, read the heading. Do not forget your heading. All of you take 55 seconds, read it, then we will analyze it. Okay, Shailaja, would you mind reading the heading and till here for me, please, if it's okay? Right.
Okay. Using a carbon monoxide test to establish smoking status in pregnant women.
So this is about carbon monoxide, using a carbon monoxide test to find out the smoking status in pregnant women. Okay, you can read the next two sentences. Go ahead, Shailaja.
Some women find it difficult to admit that they smoke because of social pressure not to. A carbon monoxide test is an immediate and non-invasive biochemical method for helping to ascertain whether they do or not.
Okay, so they are saying they need to find out whether pregnant women smokes or not. So the problem is some women, they don't like to disclose their smoking status because society has a view that women should not smoke. So because of the societal pressure, they might not disclose their smoking status. So then they are saying a carbon monoxide test is an immediate, quick, non-invasive biochemical method. So immediate, it's an urgent and non-invasive test to ascertain, to find out, to make sure whether they do smoke or they do not smoke. Okay, so this is a test to confirm the smoking status urgently, and it's non-invasive. Okay, continue till here, Shailaja, till here.
However, the best cutoff point for determining smoking status is unclear. Some suggest a level as low as 3 parts per million. Others use 6 to 10 ppm, as reliability can depend on circumstance. CO quickly disappears from expired breath up to 50% in less than 4 hours. And conversely, external influences such as traffic emissions may lead to an elevated reading.
So they are like, women might not disclose the smoking status, so we need an immediate and urgent non-invasive test to find that out, and that test is carbon monoxide test. But the best cutoff point to determine the smoking status. So what is the best point where you can find out what is the point, what is the best measurement based on which we can ensure the smoking status, or we can confirm the smoking status is unclear. The cutoff point is not clear. Some say that the point can be, if the point is 3 parts per million, or some others say 6 to 10 parts per million. So there are two versions. People say this is best, this cutoff point is best. Some people say 6 to 10 point is best. And as reliability can depend on, and whether we can trust this cutoff point depend on circumstance. So we need to find out the smoking status urgently and non-invasively. So we have a test, but the cutoff point of that test is unclear. We have not yet confirmed it because it varies. We cannot depend on it because it can vary, depending on the circumstance. Some say 3 parts per million can be the cutoff point. Some say 6 to 10 ppm can be the cutoff point. Another one thing is that carbon monoxide quickly disappears once you exhale. That means within 4 hours. So if you have carbon monoxide exposure within 4 hours after, when you breathe, based on your breaths, it can within 4 hours 50% of the carbon monoxide can get out of the body, can disappear from the body when you take breaths, when you breathe. Okay, and on the other hand, the amount of carbon monoxide in our body can be influenced by the traffic emission, the smoke of the traffic. Okay, so if we have been exposed to the traffic, then that can show a high reading. Because traffic jam and everything we get when you're in traffic, when you're traveling, or when you are stuck in a traffic, or you are just in a traffic, this one, what happens, you inhale CO, right? Because carbon monoxide is often emitted from the vehicles. So they are saying if you are exposed to carbon monoxide from traffic, then of course your reading can be elevated. Okay, all right, continue, Shailaja, till the end.
As a result, low levels of smoking may go undetected and be indistinguishable from passive smoking. It is therefore advisable to use a low cutoff point to avoid missing someone who may need support.
So they are saying women might not disclose if they're pregnant, and they might not disclose when they're pregnant, they might not disclose their smoking status because of being afraid of the society. So we need a non-invasive and immediate test, that is CO test. But the cutoff point, we are not sure about it, and it can vary depending upon the circumstance. Sometimes, if they're exposed to CO, and when they take breath, when they exhale, the CO can quickly disappear from our system. Another one thing is, if the person has been exposed to traffic, their CO reading might be very elevated, because traffic, of course, increases the amount of CO they exhale. Another one thing, so because of that, or as a result of these, low levels of smoking may go undetected and be indistinguishable from passive smoking. So if a person does not smoke much and they take the test, 1 second, Surya, I see your hands. 1 second. So there are many things. CO poisoning, it's very difficult to exactly point it out. One thing, traffic. If you're exposed to traffic, the traffic emissions, whatever the smoke and everything that comes out of a vehicle, if you have been exhaling that can be an issue. Another thing is, if you're not a chronic smoker, rather the person only smokes a little, and in such a case, it's very difficult to determine whether they are a smoker or they are exposed to passive smoking, whether they have inhaled the smoke when somebody else was smoking. It's very difficult to distinguish, because if you're a low level smoker, the amount of carbon monoxide in your system, and if you're a passive smoker, the amount of carbon monoxide in your system might not be much different. It can be indistinguishable. It can be difficult to differentiate. That is why it's always advisable to maintain a low cutoff point when it comes to CO test, in order to avoid missing someone who may need. So we cannot clearly say whether the person is a smoker or whether the person is a passive smoker. Okay, and it's difficult to, and if they have been exposed to traffic emissions, their smoking CO level can be really high. So it's very difficult to ascertain. So always, so the memo is suggesting that our cutoff point should be kept low, so we can provide support to a person. You can cover everyone. You can ensure that the person gets the support necessary, because it's very difficult to exactly pinpoint the level of CO exposure based on the habit of smoking. Surya, you had a question. Tell me, what is it?
No, ma'am, I couldn't understand because it's mentioned here. However, the best cutoff point. The cutoff point means it means the measuring amount.
Yeah. So, can I ask you one thing? What is the normal? What is the normal level of BP? Can you tell me what is the normal BP level of a person? What is that normal BP level? Yes. Can you tell me that?
BP, ma'am.
BP, blood pressure. Yeah, blood pressure. What is the normal blood pressure level?
It can go to 100 to 120 or 140.
Yeah,
it's okay.
Yeah, so that is the cutoff point. That is the normal. Above that and below that, that is dangerous. Okay. So that's what they mean by the cutoff point. The point at which above or below which we should be scared or we should be concerned. That is the cutoff point. So they are not able to pinpoint the cutoff point. Why? Because people can have CO in their system if they have been exposed to traffic emissions. If they have been a passive smoker, it's very difficult to distinguish if they are a passive smoker. Passive smoker means they do not smoke, but they get exposed to smoking because maybe their friends, maybe their family members smoke. So it's very difficult to pinpoint somebody's whether they are smoking in a CO test, because carbon monoxide level, if based on traffic emissions and based on passive smoking, it will be there in someone's system. So it's very difficult to pinpoint, and it's not clear what is the cutoff point above or below which, what is that point at which when it gets dangerous, they haven't decided it yet. Okay, so that's what they're saying. So they're saying that is, considering all these circumstances, it's always best to have a low cutoff point. That means even the low levels should be taken as a matter of concern, so we can help the people who needs help. Shailaja, Steffi, Surya, Anup, Asma, others, have you got this? Go through it. Very good extract. So please connect the sentences and understand the logic behind it. All of you, ask me if you have any question. Okay, all right. I hope I've conveyed myself clearly. Please go through this extract later. Okay, you need to connect and understand the meaning. It's a kind of a tricky one. Okay, now let's have a look at the option. So this is a question that ends in question mark. Okay, so Shailaja, just read the options. Do not read the question, just read the option.
It is a valuable tool despite its limitations.
What is it here? What does it refers to? It refers to
monitoring.
carbon
CO2
monoxide monitoring, the test. It's a valuable tool. CO2 monitoring in pregnant women is a valuable tool in spite of its limitations. What do you guys think? Is it a valuable tool? Okay, Shailaja, next option. We'll figure it out. Next option.
Clinicians should decide for themselves whether to use it.
Have they talked about clinicians anywhere in the extract?
No.
Clinicians need to needs to decide, clinicians need to decide, make the decision themselves whether to use a carbon monoxide test. Have they said that?
Nothing, ma'am.
No, nothing, right? Steffi, Surya, Shailaja, Asma, no, they have not said anything about clinicians. Next one, Shailaja.
The results should not be recorded if there are any doubts about their accuracy.
Have they talked about recording the results of the test anywhere? Come on. Go through. Have they recording, writing it down? Have they mentioned? Did we discuss that? Writing the level, recording the results of the test?
No, nothing.
No, they have not decided a cutoff point. It's very difficult to understand what this is. It is very difficult to distinguish between passive smoking and low levels of smoking. So we need to always keep a low cutoff point. That's all they have said. They have not talked anything about the results. So answer is
A.
A. Okay, no, so there, yes, it's a valuable, it's an immediate, when something is urgent, something is an immediate, quick and non-invasive biochemical method for asserting, for finding out, ensuring whether somebody smoke or not. So of course, it's a valuable tool. Yes, it has a lot of limitations which they have told here. We don't know the cutoff point. External influence such as traffic emissions can affect the reading. They have told about low level. It's very difficult to distinguish between low levels of smoking and passive smoking. So all these are limitations, but it is a still valuable tool, right? That's why they have told it's an immediate and non-invasive biochemical method that helps us to ascertain whether somebody smoke or not, somebody being pregnant women. Shailaja, Steffi, Surya, Anup, Asma, and others, have I conveyed myself clearly here? I need you to tell me whether you want me to clarify any point in this question. Are you clear why B is not the answer, why C is not the answer, and why A is the best option?
Yes.
All of
Can
you.
you explain one more, ma'am?
Once again, okay. So the memo is all about carbon monoxide test in to find out the smoking status in pregnant women. First sentence say that some people, some women have difficulty to admit, to say that, to disclose that they smoke. They have a habit. They don't say, they are very hesitant to say that they have a habit of smoking because of the societal pressure. Then they say that carbon monoxide test is an immediate and non-invasive method to find out, to confirm whether somebody smoke or not. Okay, then they go on to say that, so it's a test to confirm the smoking status because women are very hesitant to disclose their smoking status. Then they move on to say, however, but what is the cutoff limit? What is the limit above or after which the smoking level is dangerous? The CO poisoning is CO level is, carbon monoxide level is dangerous. That is that level we have not confirmed it yet. It is still unclear. The best cutoff point, we will say that, right? Until this point it's safe, until this point it's dangerous. That point we have not decided for this test. Some people suggest keeping 3 ppm as a limit is okay. Some people say no, it should be 6 to 10 ppm. Why is this confusion? Is because it's very difficult to trust the reading because it gets affected by various circumstances. As reliability, as dependency on this test is connected to the circumstance. That means based on different scenarios or situations, we have problems trusting the test. What are those scenarios? One scenario is when if somebody has been exposed to CO poisoning, CO can disappear from their system very quickly. So then if they take CO test, it of course it might not be, the reading might not be efficient, right? People have smoked or some kind of exposure to CO has happened, but when the CO has a CO, carbon monoxide quickly disappears from someone's through someone's breath or when they exhale, so it's very difficult to that is one difficulty. And on the other hand, if a person has been exposed to traffic emissions, vehicular smoke, then the reading can be high. So that doesn't mean they are smoke. When their carbon monoxide emission, carbon monoxide test shows high reading, sometimes it does not mean that they smoke. What does it mean? It means that they have been exposed to traffic emission. So that is another problem. As a result of these, so considering taking all these things into consideration, they are saying, imagine the person is a low-level smoker. That can often go undetected, and we cannot clearly say whether a person is a low-level smoker or a passive smoker. Because why? Okay, two things. One, CO quickly disappears from someone's system. Another one, sometimes even if the person is not a smoker, if they have been exposed to CO, carbon monoxide, for example, through traffic emission or through some other way, if they have been exposed to carbon monoxide, they might have elevated reading, even though they don't smoke much, they don't smoke at all. So they're saying, considering all these things, it's very difficult to differentiate whether that person is a low-level smoker or whether they are a passive smoker. Passive smoker means somebody else smokes and they're exposed to it. So is it a CO exposure or is it a CO exposure from smoking? It's difficult to differentiate. So because of all this, it's always good to keep a low cutoff point, not a high cutoff point, because we cannot exactly pinpoint the cause. It's very difficult to pinpoint the cause. It can be from traffic emission, it can be from smoking, it can be sometimes CO will disappear quickly from the body. That means only little CO will be there in the system. So that's why it's always better to keep a low cutoff point, low danger point for the CO test. That's what I said. Now the options B say that clinicians, it's up to the clinicians to make the decision of using the test. Nowhere they have talked about clinicians, so we rejected B. Then option C, they say that we need to record the results if we have any doubts about their accuracy. Accuracy they've mentioned can be a problem, but nowhere they have told about the recording it. So that's not the answer. So of course, A is the answer. A being test is a valuable tool despite its limitation. Of course, it has limitations. They have told all these things are limitations, but despite it, it's a valuable tool. That's why they said it's an immediate, it's a tool that we can use quickly and urgently, and it's a non-invasive test. So of course, it's a valuable tool, but it has limitations. So that's why A is the answer. Surya, Anu, Sefi, Shailaja, others, Asma, did I clarify myself clearly here?
Yes, ma'am.
So it's not easy to understand this text step. Please go through it later. Let's go on to the fourth question. Anu, would you like to read? Unmute yourself and read the question, if that's okay. Would you be comfortable reading the fourth question for me? Unmute yourself so I can hear you. Yes. Go ahead.
The guidelines state that radiofrequency ablation of the soft palate for snoring.
The guidelines state that radiofrequency ablation of the soft palate for snoring. So we are reading a guideline that states something about radiofrequency ablation of the soft palate for snoring. So what do we need to find out? The guidelines state that means talk about what? Talk about this topic being radiofrequency ablation of the soft palate for snoring. So what do we need to find out here? What does the guideline, yes, guideline say about radiofrequency ablation of the soft palate for? Correct. They said guidelines state this. So we need to figure out what does the guideline say about radiofrequency ablation of the soft palate. Soft palate is your mouth, okay? Soft palate, this one, soft palate for snoring. Okay. So what exactly does it say about radiofrequency ablation? It's a procedure, radiofrequency ablation of the soft palate for snoring. So the guidelines talk about this topic. So we need to figure out what does the guideline say about that particular topic. Okay, all right. All of you take 55 seconds, go through the extract. All right, Anup, can you read the heading until here for me, please? Till the second sentence, yes.
Radio frequency ablation of the soft palate for snoring, guidelines for clinicians. The intention of radio frequency ablation is to reduce airflow obstruction and vibration in the airway by snoring and tightening of soft palate. The procedure should only be used for patients whose snoring has been shown to be caused by abnormal movement of soft palate and whom sleep apnea has been excluded.
Okay, all right. So they are talking about a treatment procedure called radiofrequency ablation of the soft palate for soft palate or hard palate is related to your mouth. Okay, so the intention, the purpose of this treatment is to reduce, is to bring down airflow obstructions, problem with airflow and vibration in the airway by scarring, by making scars and tightening the soft palate. Okay, so by as making scars and by tightening the soft palate, they are trying to prevent problems with airflow. The procedure should only be used. You can only use this procedure for patients whose snoring has been caused by abnormal movement of their soft palate and in whom sleep apnea has been excluded. Excluded means eliminated. So the cause of their snoring is because of abnormal movement of their soft palate, and it's not because of sleep apnea. You need to exclude, you need to eliminate sleep apnea, and the cause should be abnormal movement of the soft palate. Only then you can recommend this procedure for patients to manage snoring. Okay, next till the end, Anu. 2 sentences till the end.
It is typically carried out under local anesthesia in the outpatient department and may be continued with other procedures such as vulvotomy and tonsillectomy. During the consent process, the patient should be made aware of the potential need for further multiple procedures at interval of several weeks if symptoms occur.
Okay, they are saying the purpose of the procedure is to deal with the airflow and by scarring, by making scars and by tightening the palate, and this can only be given to patients whose snoring is because of abnormal movement of the soft palate, not because of sleep apnea. Then they say that usually the procedure is carried out under local anesthesia in the outpatient department, and you can combine the procedure with uvulectomy or tonsillectomy. And during the consent process, when you're taking the consent from the patient, you need to make the patient aware that there may be a possibility for further multiple procedures at certain intervals, after several weeks, if there is a recurrence of the symptoms. Okay, so all of you go through it. Pretty straightforward to understand. Go through it, all of you. Soft palate is something related to the mouth. Okay, you have hard palate and soft palate, so that's what it is. Just understand that it's related to the mouth. Go through it. Go through it. Go through each and every sentence, all of you. Okay. Now, let's have a look at the options. So, as you can see, this question does not end in a question mark. Anup, can you read each question with the option?
The guidelines state that radiofrequency ablation of the soft palate for snoring could present risk of certain patients.
1 second. The guidelines, according to the guidelines, radiofrequency ablation of the soft palate for snoring could present risks for certain patients. Have they talked about risks? Shailaja, Anup, Surya, what do you guys think? Have they talked about risk of the procedure?
Nothing, ma'am.
Nothing. So we can reject it. No risks, right? They told you cannot, you can only carry this procedure if the patient's snoring is because of abnormal movement. They might need further procedures if the symptom reoccur. It can be conducted combined with other procedures, but nowhere they have talked about risks. So A is not the answer. Next option, Anu, with the question.
The guidelines state that radio frequency ablation of the soft palate for snoring might not be successful after one attempt.
Might not be successful after one attempt. What do you guys think of that? Okay.
There is in the end part.
Okay, there can be. So let's Anup, read the last option, then let's decide.
The guidelines state that the radio frequency ablation of the soft palate for snoring may lead to other type of sleep disturbance.
Did they say that the treatment may lead to other type of sleep disturbances?
Nothing.
No. So of course, answer is B. They have told that, right? After you need to make the patient aware that after the procedure, they might need to undergo it after several weeks if there is a recurrence of the symptoms. When do symptoms occur? If the treatment is not successful. So that's why B is the answer. This is pretty straightforward. All of you go through it. This is the sentence. One procedure is not enough. One attempt is not enough. They might not be successful after one attempt because they may need further procedures if the symptoms reoccur or recur. Okay. All right. I'm moving on to the fifth question for today. All right. Surya, can you read the fifth question?
Yes, ma'am. According to the memo, the new endometriosis service has been set up.
So I'll tell you one thing. Whenever they have talked about a subject, okay, then they say has been set up, okay, or organized, or given, any verb like that, you can use the question word for what? For what? So all of you go through the question, interpret it using for what? According to the memo, the new endometriosis service has been set up for what? For what? So anything has been with anything. Any verb, organized, given, has been provided. They have left it like that. You can say for what? For what? Instead of has been, if they have used a was provided, was set up, or was organized, or any verb, any V3 verb. Okay, any V3 verb for that matter, you can use the question phrase for what? For what has it been set up? So the new endometriosis service has been set up for what? Okay, now let's have a look at the extract. All of you take 55 seconds, go through the extract. Okay, Surya, can you read the heading and till here for me, please? Yes.
Yes, ma'am. Memo for family doctors. New endometriosis specialist service center. Endometriosis is a complex and often misdiagnosed illness. Evidence suggests that care may at times have been delayed due to the lack of knowledge and understanding of disease amongst healthcare workers.
I want all of you to go through this one memo. So this is a memo for family doctors. It's about a new endometriosis specialist service center. The first sentence says that this condition is a complex and often misdiagnosed illness. We often wrongly diagnose the condition. It's a complex condition. So based the proof or evidence that they have says that care may at times have been delayed. So before, the care might have been delayed due to a lack of knowledge, a lack of awareness of the disease amongst healthcare workers. So this is a complex and misdiagnosed illness. Healthcare workers were unaware, or they did not have the understanding about the disease. Because of that, at times the diagnosis have been delayed, or care have been delayed before. Okay, so that's what the evidence say. And then till here, Surya.
Yeah. To address this situation, the hospital has set up a dedicated specialist center which gives patient access to a multidisciplinary team, including a named colorectal surgeon and a nurse specialist.
To address this situation, to deal with this complex misdiagnosed illness that often, or that because of lack of awareness and lack of knowledge among healthcare workers, where the care have been delayed, to address that situation, the hospital has come up with a specialist center which gives patient access to multidisciplinary team, a team of doctors or team of healthcare professionals from different disciplines, and including especially including a colorectal surgeon and a nurse specialist. Shailaja, can you read till here now?
Initially, women will be seen by the specialist nurse.
I'm sorry, I was going for Surya. Okay, continue, Shailaja. Sorry, go ahead.
Initially, women will be seen by the specialist nurse and a full review of symptoms will be undertaken. The nurse will carry out any other incomplete or additional investigations and organize or perform a pelvic and renal ultrasound if these are not supplied with the referral.
Okay, so then they're saying at first when the women comes there, first a specialist nurse will see them, review their symptoms. Then the nurse will carry out other incomplete other investigations that they haven't done before, the incomplete one or extra investigations, and organize a pelvic and a renal ultrasound if the referral did not have it. Okay, Surya, you can read till the end now. Yes.
Detailed literature will be provided and likely next step discussed. If a laparoscopy is required, this will be organized directly by nurse who will discuss each case with the doctor and the multidisciplinary team.
Detailed literature means detailed information will be provided, like maybe leaflets or booklets, whatever they need, there will be information that will be provided, and possible steps will be discussed with the patient. Then if a laparoscopy is required, that will be organized by the nurse, and the nurse will discuss each case with the doctor and the multidisciplinary team. All of you go through it. This is pretty straightforward. Quickly go through it. Complex and misdiagnosed illness. Before, it was often care used to get delayed because of lack of knowledge and lack of understanding. In order to deal with that, they have come up with a healthcare center, service center. A nurse will see the patient, take care of all the tests and everything. Then they will give all the information necessary and what needs to be done. Everything will be discussed. Then, if needed, a laparoscopy will be organized by the nurse, and the nurse will discuss everything with the team and the doctors. Okay, all right. Now, can you read each option with the question for me, Surya?
Yes, ma'am. According to the memo, the new endometriosis service has been set up against a background of increasing referral.
Have they talked about the referrals increasing? They have set up this against because of background of increasing referrals. Have they said that?
Nothing, ma'am.
Nothing. They have said referral, saying that if the referral do not have enough additional or incomplete investigations, then they will use it. But then they will carry that out. But they have not told about increasing referrals. So that's not it. Next option, Surya.
Yeah, according to the memo, the new endometriosis service has been set up as a direct result of patient pressure.
Have they said the patients are putting pressure anywhere?
Pressure, nothing.
No. Patient pressure means when someone pressurizes someone, that's called that person's pressure. Like, have they talked about patient pressure? No, they haven't. So, of course, answer is C. Surya, can you read it?
Yeah. According to the memo, the new endometriosis service has been set up in response to earlier failings.
Earlier, they failed. Yes, they failed, right? They did something wrong. What they did, they did not, they delayed the care because of their healthcare workers were not aware how serious this was, how complex this is. So the care was delayed before, has been delayed before. So they failed. So in response to, so that's why this is the one. Evidence suggests that
Yes.
care has been delayed due to this, to address this situation, to address the delay in care. So when something has been delayed, something has not been done at the right time, that's a failing. So that's why C is the answer.
Yes,
Okay. All right. So this is pretty straightforward. I'm moving on to the final question for today. Shailaja, can you read the 6th question for me?
The main aim of the guideline about delirium is to.
So we need to find out what? We need to find out the
Aim of the.
main aim of the guideline. Main aim of the guideline, and the guideline is about delirium. Main aim of the guideline about delirium. Okay. All right. Delirium. Okay. All right. So all of you take 55 seconds, read the extract. Then we will discuss. Okay, Shailaja, can you read the heading and the first 2 sentences for me, please? Till here? Yeah.
Okay. Guideline for care home managers identifying delirium. Delirium is a common clinical syndrome characterized by disturbed consciousness, cognitive function, or perception, which has an acute onset and fluctuating course. It is a serious condition associated with poor outcomes, which can be prevented and treated if dealt with urgently.
So it is a guideline for care home managers so they can identify delirium in their patients. So delirium is a common clinical syndrome. It's it is characterized by, or the features of this condition or syndrome includes disturbed consciousness. The consciousness is disturbed, cognitive function is disturbed, perception is disturbed, and it has an acute onset, sudden onset, and fluctuating course. Fluctuating course means it is not the same way. The progress is not the same. It varies. Fluctuating course. And it's a serious condition connected with poor outcomes. The outcomes can be poor and which can be prevented and treated if dealt urgently. So if you deal with it as soon as you can, we can prevent the poor outcomes and treat the outcomes. But it's a serious condition and it has, poor outcomes. Okay, continue reading the next sentence, Shailaja.
The majority of people living in care homes fall into the at-risk category.
So majority of the people who are spending their life in a care home, they are at risk of getting delirium. Okay, next 2 sentences, please.
Delirium can be hypoactive or hyperactive, but some people show signs of both. People with hyperactive delirium have heightened arousal and can be restless, agitated, and aggressive. And those with hypoactive delirium become withdrawn, quiet, and sleepy.
So there are 2 types, hypoactive or hyperactive, and some people show signs of both types of delirium. People who have hyperactive delirium, their arousal is heightened, and they can be restless, they're agitated, aggressive. Those with hypoactive, they are very withdrawn, quiet, and very sleepy. Last 2 sentences, Shailaja.
It can be difficult to distinguish between delirium and dementia, and some people may have both conditions. If clinical uncertainty exceeds over the diagnosis, the person should be treated initially for delirium.
Some people who may have delirium, it's difficult to differentiate between delirium and dementia at times. So, and some people may have both the dementia as well as delirium. And if you have confusion about what is the exact diagnosis in a person, then first treat the patient for delirium. Okay, so they have talked about the features of delirium, how it has poor outcomes and needs to be prevented and treated urgently, and how majority of the people in a care home are at high risk of getting the syndrome, and how they've talked about hypoactive symptoms and hyperactive symptoms, and how it's difficult to distinguish between delirium and dementia. And if there is a confusion about what exactly the diagnosis is, always treat the patient first for delirium. Okay, now Shailaja, can you read each options one by one?
The main aim of the guideline about delirium is to offer advice on how to recognize different types.
So is the guideline giving us advice on how to recognize different types? What do you guys think of that? Have they talked about different types of delirium? Yes, they have.
No.
Hypoactive and hyperactive?
Yes, yes.
There
Yes,
is.
yes. Have they talked about how do you recognize a problem? By the signs and symptoms. So what do you think? Can A be the answer? Okay. Shailaja, can you read the other two options and let's decide.
The main aim of the guideline about delirium is to stress the importance of monitoring symptoms.
Have they talked? They have talked about symptoms, but have they talked about monitoring symptoms?
No, nothing.
No.
Nothing
No.
is there.
No, they have they talked about how important it is to monitor symptoms? Have they highlighted that point? Stressed it. They've talked about symptoms, the features of delirium, but have they talked about the importance of monitoring those symptoms? Not exactly. Next one, Shailaja.
The main aim of the guideline about delirium is to suggest ways of managing patients' behavior.
Have they suggested ways through which we can manage a patient's behavior?
No, nothing.
No. So D is not the answer. C is not the answer. Answer is A. So they have told us what is hyperactive, what are the symptoms of hyperactive delirium and hypoactive delirium, and they have told us the symptoms. So that means they're telling us how to identify the both. So that's why they're giving us advice on how to recognize. Because see, if somebody has hyperactive delirium, then these are the symptoms. If this is hypoactive, they have these are the symptoms for that. So we can identify between both. We can recognize the difference between both. Okay, so that's why A is the answer. They have talked about symptoms, but not monitoring. No, no, they have not talked about monitoring for the symptoms. No. Okay, so this is a very good question. Answer for sixth one is option A. Okay, all right. So we have covered all the questions for today. So today's material is the latest material, and it's kind of the extracts are very new, and the language, the way they have connected ideas, it's a bit tricky. So please go through this material again, and if you have any questions, ask me later. One more thing, let me just say a few things. So yesterday's writing class got interrupted, so I will be conducting that class on 2 p.m. Friday. Then invite for tomorrow's sessions, morning session, afternoon session, and evening session will be sent in your groups before 40 minutes before each session. Okay, all right. So tomorrow you will have Richa ma'am's speaking as well. Okay, all right. And all the notes for morning session reading part A with extra material for reading part A, today's material with one extra material, everything will be sent in your virtual classroom group as well as reading listening group. Okay, so please go through this material, and if you have any questions, make sure to ask me. Okay, so I think that's it for today. I'll see you guys tomorrow. Okay, all right. Thank you.
Okay. Thank you.
Thank you.